Hello, everybody. I went to a training recently for teaching online, and they suggested that rather than having me respond to every discussion board that you post, that to do a video and respond to all the things that I think might be helpful to you from your discussion boards that I otherwise had previously been posting, and I'm not sure if everybody sees them or not. But hopefully that you'll see this video of with some of the responses, and that I hope that you'll find this helpful to you. Um, Anyways, I hope you're doing well, and I am enjoying working with you this semester, and everybody is keeping up for the most part. And um, if you're having difficulty, just let me know, and we'll work really hard to work with you. I know you have a lot on your plate, especially with wrapping up and beginning a new semester here. So I'm going to respond mostly to the section on cognitive disorders and personality disorders. And I'm I'm a lot more knowledgeable about personality disorders than I am about the cognitive disorders. So I don't have a lot to add. I have a couple of comments to make about cognitive disorders. And why don't we start with that? And so I'm not going to really say a lot more about cognitive disorders, but the most important thing that I think that you should know in assessing cognitive disorders is the difference between delirium and dementia. There are several different kinds of dementia, but they have similar characteristics. So what's really important to know is that delirium is pretty short term, can happen to anyone, especially older adults who go into the hospital for some kind of surgery. They may become very disoriented, very frightened, try to pull their IVs out. It happens to them more often in the evenings. It's called sundowning. So it arises abruptly and it goes away abruptly, whereas dementia is much more serious and long term. Dementia symptoms arise slowly and tend to get worse over time. And Alzheimer's form of dementia, for example, is the only DSM diagnosis that I'm aware of that is also a medical diagnosis. So Alzheimer's eventually takes the person's life. So that's the biggest comparison difference I think you need to be aware of, and I think you might see that on a test someday coming down the road. So let me talk a lot about personality disorders, just kind of going off from your discussion boards today. Let me begin with, if a person has a personality disorder, it's never going to get cured. That is who they are. That's their personality. And we can treat symptoms. We can hopefully help alleviate some symptoms. But for most people with personality disorders, they don't want our help. They don't seek treatment. They don't think that they have a problem. They view the problem as external and not internal. Um, and I'll be talking about a number of different kinds of personality disorders here, and pointing out that how they are different from other kind of mental health conditions. For example, differentiating obsessive compulsive personality disorder from obsessive compulsive disorder. And there are a number of differences, as was noted on the discussion board. But one of the really key things to be aware of when you're trying to assess, if somebody is OCD or if they're have an obsessive compulsive personality disorder, is whether or not they're troubled by their symptoms. So somebody with OCD is very troubled by their symptoms, and they'll let you know. They're not in denial. They'll let you know it's really, really hard for them to have to do everything a certain way and to keep checking all the time. A person with obsessive compulsive personality disorder doesn't understand why everybody doesn't alphabetize their vegetables. They think that what they're doing is appropriate and right, and get offended when somebody tells them otherwise. And this is the way they like to do things. They're they may be very scrupulous, they may be very organized, um, and they may be frustrating to everybody that's around them who can never quite live up to their demands. Um, Okay. So the whole issue of ego syntonic versus ego dystonic is a really important one, and this is a key area to talk about that. Um, some conditions, like personality disorders, are ego syntonic. The person is not troubled by their symptoms. They're not experiencing a lot of pain as a result of their symptoms. Whereas people who are ego dystonic, for example, somebody suffering from major depression, is probably the most painful thing that a person can experience, and they can tell you how horrible it is, and it's an ego dystonic kind of condition. So a lot of conditions, like I think I talked about this with substance abuse, are egosyntonic condition. The cocaine is not my problem, it's what makes things better. Alcohol is not my problem, it's what makes things better. And for those folks, it's helpful for them to get in touch with the pain that their condition is actually causing. So let's see, what else do we have? Um, again, people with personality disorders can be treated, sometimes are treated, but rarely will seek treatment. The only exception to that really is people with borderline personality disorder. A lot of times they will seek treatment, I think most often in an effort to try to fix somebody else, um, rather than a willingness to take a look at themselves or validate their side of things. Um, and certainly they do seek treatment, and we can hopefully slow down some of the symptoms, reduce the symptoms, reduce the number of suicide attempts, reduce the number of times that they're cutting, um, and you try to reduce the hospitalizations, for example. Um, let's see. Um, there's a comment about how personality disorders change in the DSM-5 with under the section for recommendations for future study, and actually all they've done is reduce the number of them. I forget exactly what it is, 12 to 9 or something like that, but the criteria aren't changed. Okay, let's see. Um, Paranoid personality disorder, like borderline and narcissistic, people have very turbulent relationships. Somebody commented about they wonder what the divorce rate is. Certainly, it's got to be significantly higher because people with any of these three conditions are going to get into relationships. They're going to be awful, and it's going to be hard to maintain long term. Um, the other one that falls into that category is histrionic, and I thought I'd give you a case example of someone that I dealt with that was histrionic. When I was in the Air Force, I was running a program to reduce family violence, including spousal abuse, and I got a call from a commander and asked me to see this couple. And let me tell you a little bit about the scenario that helps to kind of uh, help you understand what the histrionic personality is. So, first of all, you got to understand that the husband was a captain in the Air Force. He was a pilot. Pilots in the Air Force would rather fly than do anything. Their career is very important to them. But an Air Force officer has to be really careful to keep their nose clean, not get into trouble, and certainly not irritate their commander. Anyways, this guy's wife walks into the wing commander's office, demands to see the commander. The secretary says you can't see him right now because he's with somebody or he's busy, and she just walks right in anyways. And I got to describe what she's wearing. She's wearing like a spaghetti top with a bare midriff and short shorts, and she walks over and pounds on the commander's desk and says, "You got to do something about my husband. He's being verbally abusive." And so the commander, who wants to fly airplanes and do the Air Force mission, does not want to be bothered with the difficulties that people are having in their marriages. And so he picked up the phone and called me. And so we started working with them, doing some couples counseling with them. And one morning, my office door was open, and I hear this commotion going on at the receptionist desk. And I look out to see what's going on, And this woman is yelling at my receptionist saying, "You've got no right to be seeing my husband here without telling me about it. And I'm going to cause trouble and this is terrible." Then she's stomping down the hall and walking right into the office where one of my social workers is in meeting with her husband, and just is yelling and very inappropriate. So she's got all the kind of classic qualities of a histrionic, just attention seeking and being dressing in a provocative kind of way for attention, and very turbulent relationships. So that's my histrionic story. Let's see. When you're looking at differentials for personality disorder, sometimes substance abuse is something that's worthy of looking at, but generally we're trying to figure out which personality disorder is this. So generally the best differential is, okay, is this narcissistic or is this histrionic? Okay, and trying to differentiate between the two. That's the most common kind of differential for personality disorders. Um, let's see. Although for avoidant personality disorder, a really good differential is social anxiety disorder. But here again, as I mentioned with all personality disorders, an important question to look at is, does the person feel in pain about their symptoms? The person with avoidant personality disorder does not. Okay? They view this as other people's problem. Other people are nasty. I'm not going to be around them because they're nasty. So the person with social anxiety disorders would like to be around people, but they're very frightened of them. So fear is the predominant symptom. And they know that there's something wrong with them. They wish that there wasn't, but it's just the way it is. Um, okay. Dependent personality disorder is maybe a little hard to understand. But I think a really good example of it was on Everybody Loves Raymond reruns. Raymond's brother Robert is trying to decide whether or not to retire from the police force, but he can't make a decision because Raymond and his wife say that he should not retire, or they should retire, I think, and his parents say that he should. So he bases his decisions on what other people are thinking and wanting him to do, and not even, like he's an adult man. If it was a spouse or a partner, then their input might be more important. But he's very dependent on other people for their opinions for influencing him. So one of the things, though, that and some people commented on this. I know somebody that sounds a lot like this. A lot of people have personality traits that fall into one of these categories. Some people are a little more, kind of go with the flow, do what other people say, than other people. It doesn't mean they have a dependent personality disorder. So they have to meet all the criteria. So, even as you're reading this, you may say, "Oh, that's a little bit like me. I'm kind of quiet. I don't like to be around people that much. Maybe I'm schizoid." No, it really is, you have to put all of the characteristics together. Um, okay, let's see what else we got here. Another co-occurring disorder with borderline personality is alcohol and substance abuse. Um, and I have worked in inpatient substance abuse treatment, or worked there for quite a few years, and I can tell you, if you have one borderline person in the group, and yes, they have an alcohol problem or a substance abuse problem, their prognosis is really poor, and they make life very miserable for everybody around them in the group. It's really tough to do a group when you have one person there that is but that has a borderline personality. So I had a question, an email question today about the next section. So this is a really good question, and I thought I'd go ahead and just address it for everybody, which I would do if I was teaching a regular class here. So the question is, as I was reading about the sexual dysfunction disorders, I'm wondering, as a social worker, do we diagnose them, or would a medical professional diagnose them after doing examinations and medical testing? Can you give me an example when we as a social worker would diagnose and when we would not? I can't find examples in the book. Okay, really good question. Okay, so MSW social workers, we do a lot of marital work, probably more so than anybody else. I think mental health counselors are probably catching up with us now. Um, and we talk with clients about sexuality and sexual issues. So that needs to be a part of the work if you're working with a couple that is in a sexual relationship. But and we don't diagnose any sexual disorder unless you have specialized training. It's just like you don't do hypnotism unless you've had specialized training to be able to do it. You're not competent to diagnose and treat sexual dysfunctions if you're not a sex therapist. Now you could become a sex therapist, and you could get additional training after your MSW to do that, and then you could do the diagnosing. But do not ever put on your business card that you are a sex therapist unless you've had additional training that makes you competent to be able to do that. So no, when you graduate with your MSW, you cannot go out and start treating people for sexual dysfunction. You can talk to people about their sex, what's going on for them sexually, but if they have one of the sexual dysfunctions listed in the DSM-5, then you don't diagnose that and you don't treat that. Okay, hope that's helpful. So I thought I'd try this. I'm interested in feedback if this was helpful, if this answers your questions. If not, if it raises more questions, please respond in the question and answer section, and I'll get back with you there. But I'm going to try this instead of responding to each of your discussion boards, and that's why you'll notice for this, for yesterday's discussion boards, I didn't comment on anybody. But let's see. So I think that's it. For this last discussion board on cognitive disorders and personality disorders, some people did one and not the other, and I was looking for you to do both. So, anyways, just to comment on that. Just the only other thing that some people are very thorough in doing their discussion boards, and for this class as well as future ones, you'll probably do discussion boards in. Make sure that you articulate yourself, fully. So if you're looking at doing a differential on somebody, and you say, well, this person has bipolar disorder, but maybe the differential could be schizophrenic because they might have schizophrenic symptoms, that's kind of not enough, okay? You need to talk about, well, why did you consider schizophrenia? What is it about schizophrenia that looks like bipolar disorder, so that you can differentiate between the two? Okay, so don't just throw out a DSM diagnosis and say this is a differential. Explain why and what you're talking about. I feel that'll be a lot more useful for you. Okay, that's it. Hope you're having a great day, and I'll talk with you again soon. All right. I'm going to post this as a YouTube video and send you the link. Bye-bye.